Hey there, and welcome back to the deep dive.
Hello.
Today we're getting into a specific set of revision notes. The topic is renal artery stenosis.
That's right.
So if you're prepping for something like the MSRA or maybe a clinical discussion, or you just want a really focused high-yield overview, well, this is for you.
Exactly. We're going to unpack these notes, hit the key information definition, causes, right through to management and complications.
Think of it as us pulling out the absolute must-know points from this source material for you. Ready to jump in?
Let's do it. The goal is to make this stick. Renal artery stenosis, it sounds specific, but it has big effects, especially on blood pressure and kidney function. Understanding those links is crucial.
Okay, let's start right at the beginning then. The definition. What are we actually talking about here?
Fundamentally, it's pretty simple. A narrowing, a stenosis of one or sometimes both renal arteries.
Those are the main pipes supplying blood to the kidneys, yeah.
Precisely. The main blood supply.
And if they narrow, what happens? What are the consequences these notes highlight straight away?
Well, logically, you get reduced blood flow to the kidneys. And that impaired flow affects kidney function, as you'd expect.
Mm-hmm.
But the really big one, the thing that often brings patients to attention, is hypertension. High blood pressure.
Right, and often high blood pressure, that's like really difficult to get under control.
Exactly. Resistant hypertension is a major clue. And the notes quickly point to the two main reasons why this narrowing happens.
What are?
Atherosclerosis, hardening of the arteries, the usual suspect in vascular disease, and something called fibromuscular dysplasia, or FMD.
Okay, we'll definitely dig into those more. Does the source give a threshold for how bad the narrowing needs to be?
It does. It defines severe stenosis as more than a 70% reduction in the artery's diameter. So quite a significant blockage.
70%, wow. And that other cause, FMD, you mentioned it's different from atherosclerosis.
Very different typical patient. Atherosclerosis, you're thinking older individuals, maybe with other cardiovascular risk factors.
Right.
FMD, on the other hand, tends to hit younger people, often under 30, and it's notably more common in women. That's a key demographic difference to remember.
Good point. Older versus younger female. The notes mention a few other rarer causes too, don't they? Like neurofibromatosis, trauma.
Yeah, aneurysms, clots, trauma. They're lifted, but honestly, atherosclerosis and FMD are the big players. They cover the vast majority.
Okay. And even here in the definitions section, the notes start connecting the dots to the underlying mechanism, mentioning renin release.
Yes, they tee it up early. That reduced blood flow, the renal ischemia, it triggers the kidney to release an enzyme called renin.
Ah, renin. And that kicks off the whole RAAS cascade, right? The renin angiotensin aldosterone system.
You got it. That's the crucial pathway. Renin leads to the production of angiotensin II.
Which is a potent vasoconstrictor.
Squeezes blood vessels. And it also stimulates aldosterone release.
Aldosterone makes the kidneys hang on to salt and water.
Exactly. So you've got tighter blood vessels and more fluid volume. The net effect, as the notes spell out, elevated blood pressure. This activation of RAAS, because the kidney thinks it's not getting enough blood flow, is absolutely central to the whole condition.
So the kidney's trying to fix low pressure locally by shouting for more pressure systemically, but that just makes the overall hypertension worse and potentially harms the kidney more in the long run.
That's a great way to put it. It's a maladaptive response triggered by the stenosis. Visualizing that chain. Narrowing less flow, kidney panics, RAAS fires up, blood pressure rises, and kidney function can decline. That sequence is key.
Okay, super important. Let's dig into those causes, the etiology, a bit more then. Atherosclerosis and FMD.
Right. So atherosclerosis, the notes are clear. This is the most common cause by far, especially in older people with those typical vascular risk factors, smoking, diabetes, high cholesterol.
And it gives a number, doesn't it?
It does, and it's a big one to remember. Atherosclerosis accounts for about 90% of renal artery stenosis cases.
90%. Okay, so if you have an older patient presenting, you're strongly suspecting atherosclerosis.
Definitely your top differential for the cause. And then fibromuscular dysplasia, FMD, as we said, is the one to think about in younger patients, especially women. It's a different kind of arterial wall problem, not plaque buildup.
So maybe a little memory aid? A for atherosclerosis, think age, almost all, 90%. F for FMD, think female, fewer years.
That works. Whatever helps lock it in. The notes also list things like arterial dissection, vasculitis, even external compression again here, but yeah, focus on the main two.
Got it. Okay, who's most likely to get this? What are the risk factors mentioned in the source?
Well, given that atherosclerosis is the main driver, the risk factors overlap a lot with general cardiovascular disease. So older age is one.
Makes sense.
Lifestyle things like smoking, major factor.
Always.
And then existing medical conditions,
Yeah.
hypertension itself, diabetes, hyperlipidemia, high cholesterol.
So pretty much the standard cardiovascular risk checklist.
Largely, yes.
Yeah.
But there's one more specific one mentioned. A family history of renal artery stenosis itself.
Ah, okay. So the usual suspects plus a potential genetic link.
Exactly. Think standard CV risks plus that specific family tendency.
Right. Now, let's really cement that core mechanism, the pathophysiology. Can you walk us through it again, step by step, how the narrowing causes the problem?
Okay, so step one is the physical narrowing of the renal artery. That's the stenosis.
Less space for blood to flow.
Right. So step two, reduce blood flow, reduce perfusion, reaching the kidney tissue downstream.
The kidney notices this.
Yes. Step three, the kidney interprets this low flow as meaning the entire body's blood pressure is too low. It doesn't know it's just a local supply issue.
So it tries to fix it.
Exactly. Step four, it activates the renin angiotensin aldosterone system. It releases renin,
Renin kicks off the cascade.
leading to increased angiotensin II. Step five, angiotensin II constricts arterioles all over the body, raising peripheral resistance.
Squeezing the pipes.
And it also tells the adrenal glands to release aldosterone. Step six, aldosterone makes the kidneys retain sodium and water.
Increasing the fluid volume in the circulation.
So step seven, you have both vasoconstriction and increased blood volume. The result, hypertension, chronic high blood pressure.
And over time, that reduced flow and the effects of chronic RAAS activation also damage the kidney itself, right?
Absolutely. That's the other major consequence alongside the hypertension, progressive impairment of renal function. So that chain. Narrowing low kidney flow, now low kidney flow, potential arteries activation, systemic vasoconstriction, plus sodium water retention, now it's high BP, plus kidney damage. Understanding that flow is everything.
It really explains why the symptoms are what they are. It's like a vicious cycle initiated by the kidney's response.
Precisely. A maladaptive feedback loop.
Okay. Now, when someone comes in with, say, really tough to treat hypertension or maybe declining kidney function, renal artery stenosis isn't the only possibility. What else is on the differential diagnosis list according to these notes?
Good point. You need to consider other things. The most obvious is primary hypertension, sometimes called essential hypertension, just high blood pressure without a clear secondary cause like RAS. That's much more common overall.
Right. What else?
Chronic kidney disease from other causes like diabetes or glomerulonephritis. You need to figure out if the kidney disease is the cause or the result of something like RAS.
This makes sense.
The notes also mention renovascular diseases as a broader category and other renal artery diseases. Basically acknowledging other rarer things can affect the kidney's blood supply too, like aneurysms or dissections perhaps. And also, primary aldosteronism needs ruling out.
So it's about thinking, could it be RAS, or is it primary BP, or another kidney issue, or something else affecting these vessels?
Exactly. You're trying to pinpoint the underlying driver.
And what about epidemiology? How common is this, say, in the UK? Do the notes give us figures?
The notes specifically mention the UK prevalence data isn't readily available in this particular source.
Ah, okay. So no hard numbers here, but it does reiterate the typical profile.
Yes, it reinforces that you're commonly seeing this in older individuals, the ones with those cardiovascular risk factors, existing hypertension, atherosclerosis. That profile comes up again and again.
Understood. So moving to how it actually looks in a patient. What are the clinical features? What signs or symptoms might make you suspect renal artery stenosis?
Well, it can vary. Some people might actually be asymptomatic, and it gets picked up incidentally.
Okay.
But the big flashing light, the one really emphasized in the notes, is uncontrolled or resistant hypertension. Blood pressure that just won't come down despite being on 3 or more different BP meds, including a diuretic.
That makes total sense given the RAA overdrive we talked about.
Exactly. Other things could be symptoms related to declining kidney function, renal impairment or ischemia, maybe fatigue, changes in urination, though often non-specific early on.
And it's a key cause of secondary hypertension, right? High BP due to another condition.
Absolutely. It's one of the most common treatable causes of secondary hypertension, which is why identifying it is so important.
Anything specific you might find on examination?
Yes, there's one classic sign mentioned, an abdominal bruit.
Explain that.
It's a whooshing sound you might hear with your stethoscope when listening over the abdomen, usually slightly off the midline in the upper quadrants. It's caused by turbulent blood flow rushing through that narrowed renal artery.
Like hearing rapids in a narrowed river channel, a sign of blockage.
Good analogy. Not always present, but if you hear it, it's highly suggestive. The notes also mention edema or swelling can occur.
And how does that link back?
That links directly back to the increased aldosterone from RAAS activation, causing that sodium and water retention we discussed.
Got it. So key flags, resistant hypertension, maybe an abdominal brute, possibly some edema, all pointing back to that RAS mechanism. Okay, so you suspect it. How do you confirm it? What investigations are listed?
Right, you need to confirm the diagnosis and see how bad the narrowing is. The notes break it down into blood tests and imaging.
Let's start with bloods. What are we looking for?
Primarily, you need to check kidney function, urea, and electrolytes, paying close attention to creatinine and potassium. This gives you a baseline and helps monitor things, especially if there's already some chronic kidney disease or CKD.
Okay.
A lipid profile is usually done too, given the strong link with atherosclerosis. And the notes also mention checking the aldosterone to renin ratio.
Why that one?
That helps differentiate RAS from primary aldosteronism, where you'd see high aldosterone but suppressed renin. It's part of working through the differential diagnosis.
Okay, blood test done. What about imaging to actually see the arteries?
Imaging is key. Often, the first step is a duplex ultrasound or Doppler ultrasound of the kidneys and renal arteries.
What can that show?
It's not invasive, uses sound waves. It can visualize the kidneys, measure their size, look at the arteries directly, and importantly, measure blood flow velocities. High velocities can indicate a narrowing.
So a good screening test.
Generally, yes. If that's suggestive or if suspicion is high, you might move to MRA or CTA.
Magnetic resonance angiography or computed tomography angiography.
Right. These give much more detailed pictures of the renal artery anatomy. You can really see the vessels clearly.
Down science.
The notes mention they require contrast agents, gadolinium for MRA, iodine for CTA. You need to be cautious with contrast if kidney function is already significantly impaired.
Makes sense. And what's considered the gold standard according to this source?
That would be conventional renal arteriography, sometimes just called angiography.
How does that work?
This involves inserting a thin tube, a catheter, usually via an artery in the groin, threading it up to the renal arteries, and injecting contrast dye directly while taking X-ray images.
So you get a direct, real-time picture.
Exactly. The notes say it's the most sensitive test for showing the anatomical narrowing, and it's crucial for planning treatment because often you can perform an intervention like angioplasty at the same time.
But it sounds invasive.
It is. It carries small risks associated with arterial catheterization bleeding, vessel damage, reaction to contrast. So it's usually reserved for when the non-invasive tests are unclear or when you're pretty sure you'll need to intervene.
Okay, so the usual path might be blood stool to sound, maybe MRA-CTA angiography if needed for confirmation or treatment planning.
That's a typical flow based on these notes.
Right, diagnosis confirmed.
Yeah.
How do we manage renal artery stenosis? What's the approach outlined here?
It's definitely multifaceted. It starts with the foundations, things that help cardiovascular health overall. So, lifestyle modifications.
Like what?
Smoking cessation is huge. Getting blood pressure under better control through diet, exercise, and meds. Managing cholesterol. The notes also specifically mention weight loss and following a low-salt diet.
These tackle the underlying risks and the consequences, yeah.
Exactly. Then comes medication, primarily for controlling the hypertension. ACE inhibitors, or ARBs, angiotensin receptor blockers, are often first-line choices. The notes give captopril as an example, ACE inhibitor. Diuretics might also be added.
Okay, but hang on. There was that really important warning about ACE inhibitors and ARBs in this specific condition, wasn't there?
Absolutely critical point, yes, and definitely high yield for exams. The notes stress using ACE inhibitors and ARBs with extreme caution, especially if the stenosis is severe or bilateral, affecting both kidneys.
Why is that?
Because in severe stenosis, the kidney relies on the vasoconstriction effect of angiotensin II, part of that RAAS system. On the efferent arteriole, the vessel leaving the kidney's filter to maintain enough pressure within the filter, the glomerulus, to actually function.
Oh, okay.
If you block RAS with an ACE inhibitor or ARB, you block that efferent constriction. The pressure inside the filter can plummet, leading to a sharp drop in kidney function, sometimes acute kidney injury.
Wow. So the very drugs used to treat the hypertension it causes can actually harm the kidney if the stenosis is bad enough.
Precisely. It's a real balancing act. You have to start low, go slow, and monitor kidney function creatinine very closely after starting or increasing the dose of these drugs in patients with known or suspected RAS.
That is such a crucial detail. Okay, what other meds are mentioned?
Well, because the cardiovascular risk is so high, the notes emphasize managing that aggressively. So statins for cholesterol lowering are almost always indicated, and antiplatelet agents, like low-dose aspirin, to reduce the risk of clots and events like heart attack and stroke.
Right, so it's not just about the kidney artery, it's about protecting the whole cardiovascular system.
That's a major theme. Reducing overall cardiovascular risk is paramount.
And what if lifestyle and meds aren't enough, or the stenosis is really severe?
Then revascularization procedures come into play.
Yeah.
The aim is to physically open up the narrowed artery to restore better blood flow.
How's that done?
The main approach mentioned is endovascular, usually percutaneous transluminal angioplasty or PTA.
Ballooning the artery open.
Yes, a balloon on a catheter is inflated inside the narrowed segment. Often, a metallic meth tube, a stent, is placed at the same time to help keep the artery propped open.
Angioplasty with stenting.
That's the commonest interventional approach. In some selected cases, usually more complex situations or if endovascular fails, surgical revascularization might be considered. This could be a bypass graft around the blockage or reconstructing the artery itself, but surgery is less common now.
Okay, so the strategy is lifestyle first, meds for BP, cholesterol, antiplatelets with that ACE/ARB caution. Revascularization if meds fail or stenosis is critical.
That summarizes the management pathway described in these notes well.
What about the long term? What's the prognosis like for someone diagnosed with renal artery stenosis?
It's variable. The notes make it clear the outlook isn't fixed. It depends heavily on a few key things.
Such as?
The underlying cause is important. FMD, for example, might behave differently or respond differently to treatment than extensive atherosclerosis.
And the severity of the narrowing must matter hugely.
Absolutely. The degree of stenosis is a major predictor. How much blood flow is getting through, how much has kidney function already been affected.
Other health problems would play a role too, I imagine.
Definitely. Comorbidities, things like diabetes, heart failure, existing widespread vascular disease, they all impact the overall prognosis.
But is there anything that gives a more positive outlook?
Yes, and it's what we always hope for. Early detection and effective management. If you catch it early, control the risk factors, manage the blood pressure well, and intervene appropriately if needed, you can significantly improve outcomes and slow down progression.
So, cause, severity, other illnesses, and how well it's managed, those are the big factors determining the future.
Those are the key determinants listed.
Finally, what are the potential complications? What can go wrong if renal artery stenosis isn't managed effectively or if it progresses?
A lot of the complications flow directly from the pathophysiology we've discussed.
Huh.
Uncontrolled hypertension is a big one. That persistent, difficult to manage high blood pressure itself causes damage over time to blood vessels, the heart, the brain, the eyes.
Right, and the kidney itself.
Renal impairment is a direct complication. The reduced blood flow can cause progressive damage leading to chronic kidney disease. In severe, untreated, or bilateral cases, this can sadly progress all the way to renal failure or end-stage renal disease, needing dialysis or a kidney transplant.
A very serious outcome.
Extremely serious. And then, tying back to that cardiovascular risk theme again, major cardiovascular events are listed as key complications.
Heart attacks, stroke.
Exactly. Patients with RAS are at significantly higher risk for these events. Managing RAS is partly about preventing these devastating complications.
And the notes also mention medication side effects as a potential issue.
Yes, acknowledging that the treatments themselves aren't without potential problems like the ACE inhibitor issue we discussed, or side effects from other drugs.
But the takeaway is positive if managed well.
Yes, the source reiterates that prompt and effective management can significantly lower the risk of developing these complications. It underscores the importance of diagnosis and treatment.
Okay, so let's try and connect those dots one last time for memory. You've got the cause, atherosclerosis FMD, leading to risk factors, age, smoking, etc. This causes narrowing, reduced flow, pro or RAS activation, the core pathophysiology. That leads to the clinical features, resistant HTN, brute. We use investigations, ultrasound, angio to find it. Then management, lifestyle, meds carefully, procedures. The prognosis depends on severity cause management. And if untreated, serious complications, HTN crisis, renal failure, CV events, can occur.
That's an excellent summary of the flow. Keeping that narrative, especially the central role of RAAS linking the stenosis to the hypertension and kidney issues, really helps tie all the facts from these notes together.
Thinking about this whole picture, what strikes you as maybe the single most important takeaway message from these notes, something for listeners to really focus on?
Beyond just knowing the definition, I think it's the source's consistent, strong emphasis on the cardiovascular risk. It hammers home that renal artery stenosis isn't just some isolated kidney plumbing problem. nor just a cause of high blood pressure. The very mechanisms involved, especially when driven by atherosclerosis, mean this condition acts as a major amplifier of systemic cardiovascular risk. It significantly raises the chances of having a heart attack or a stroke.
So, a final thought perhaps for you listening. Why is tackling this specific artery issue potentially so crucial for protecting the heart and brain, not just the kidneys?
It's because the RAAS overactivity it triggers has systemic effects, and it often occurs in people already burdened with cardiovascular risk factors. Treating the stenosis, controlling the resultant hypertension, managing lipids, using antiplatelets, it's all part of a bigger strategy to reduce that patient's total cardiovascular risk load. The notes constantly link management back to preventing those wider cardiovascular events.
That's a really powerful point about interconnectedness. Well, that brings us to the end of this deep dive into renal artery stenosis, based strictly on these revision notes.
We've covered a lot: definition, causes, pathophysiology, presentation, investigations, management, prognosis, and complications. Hopefully, breaking it down like this makes it clearer and easier to recall for you.
Our aim was definitely to pull out that high-yield info, connect the key concepts like RAAS, and make this genuinely useful for revision or just getting up to speed fast.
And remember, if you want more revision materials, practice questions, and deep dives into other key medical topics, there are resources available.
Absolutely. Just head over to passthemsra.com. That's passthemsra.com. And also check out freemsra.com for more free resources.
Great places to continue your learning. Thanks for joining us for this deep dive.
Yeah, thanks for tuning in. Keep up the great work, and we'll catch you on the next one.